So yeah, thanks for having me. So yeah, but my title has kind of been covered already. So I will be looking at dementia, relationships and care with a gendered aspect to some of the discussions. I think Fiona's just going to pop up again if I sort of get to 35 minutes. If I'm still waffling, I just maybe have slightly over prepped in terms of the content today, but should still give you hopefully a nice insight into some of my work, and hopefully I'll have got past slide 1 by the end of the 35 minutes as well. So just to give a bit of a framework to what I'll be addressing, so very much in line with the title, but I'm really keen, because again, just to give a little bit of context, academic context, I have a sort of a sociological background. Don't necessarily refer to myself as being a sociologist. I've been based in sort of health and social care really all my career, so I'm not quite entirely sure what I am, but yeah, certainly there's a sociological background and aspect to my orientation. My first degree was in sociology many years ago. I'll start off a little bit theoretically, conceptually, just look at some terms. You may be familiar with them already, and certainly you'll be familiar with some of the things these concepts feed into in research terms, and also personhood really in terms of practice as well. And as you would expect, drawing on my own research insights into gendered experience as well. And I'll cover a little bit about methodology. Like I say, I'm probably taken on a bit too much for 35 minutes, but important just to give a bit of a sense of how I've done things methodologically and in terms of method as well, because of course all these things are integrated. But yeah, I'll just start off a bit conceptually, just talking about some of the theory, the models that inform qualitative dementia research. So the key thing, as I've mentioned, is that what informs my research, and I'll draw on particularly just a couple of studies I've undertaken where I've interviewed couples, and I'll discuss the sort of the methods behind those studies a bit more. But to stick with the sort of concepts for now, so just what's important is to recognize these things sound obvious, but somehow when we're talking about, well, health, sometimes illness, and dementia, we somehow lose sight of the person. We deal with the condition first, and of course we're aware of how even the terminology we use with dementia, we'll refer to the person with dementia, the person living with dementia, rather than terms which we may see sometimes in perhaps in more general media, things like dementia sufferer, for example. But we need to be cautious about the language we use without perhaps becoming entirely mired in discussions around language. So when we're talking about the relational basis of experience, it's that socially constituted personal experience, and again, that sociological orientation, not treating things or dealing with things in some sort of atomized sense as though we have sort of individual experience. It's always relational. Would we dispute our own lives that we ever engage in something where we're not engaging with others, we're not shaped by social and cultural factors? Would we want ourselves to be reduced to our biology, to our neurology, or if we had a condition such as dementia, a neurodegenerative condition? And just that quote there, just pinning this down, the experience of dementia is relational and not simply cognitive, rather. Because we could just say that about life, couldn't we? That our experience as humans is not simply cognitive. We are relational agents, and even I will talk about this. My sample, it tends to be people who can take part in qualitative research, less likely to be towards the severe end of the continuum in terms of the dementia. Nevertheless, it's still, when we're talking about, we'll just move on to talk a bit about personhood. It's about recognizing, even at the advanced stage of the condition, the kind of irreducible personhood to the person living with dementia. And just that quote there, Kitwood, writing in the 90s, still regarded to be a seminal writer, seminal text on personhood and dementia. And we get there, it's that really drawing out this kind of, I suppose, the relational orientation that I'm discussing. We can get into a critique of the way he's defining the term there. As you'd imagine, most definitions are open to a degree of critique. But I suppose what the value, let's talk about first of all, was shifting away from this sense that it's simply about biology, it's about neurodegeneration, it's about a more humanistic sense of recognizing the person and the importance of relationships. So very important to recognize, the value of Kitwood's work. There are critiques of Kitwood's work, and I suppose I've included it within my own papers about, is it a little too individualized? Does it recognize sufficiently the role of sort of social and cultural factors? And even in that definition there, the sense of it being a status bestowed, does it actually perhaps understate the agency of the person, as well as if it's a status that's simply granted by others? Nevertheless, a really valuable and influential definition that moves us away from this sense that we can reduce a person to their biology. And another term very much associated with Kitwood is the notion of sort of malignant social psychology, where other people demonstrate behaviours or exhibit behaviours that have a negative impact on the person with dementia, such as infantilization, which I've mentioned there, or disempowering the person as well. Alternatively, of course, positive care environments can help to nurture and sustain positive arrangements, positive status of the person with dementia as well. I'll hopefully come back to that term as well when I move on to talking about a relational sense of dementia, thinking about the carer partner as well. That you need to avoid some sense, like I say, some individualized sense, as I've mentioned, that we're just thinking almost about the individual, then we work outwards. Often in a care relationship, there's more than one vulnerable person. Is there some risk when we start to these terms? The malignant social psychology is supposed to jolt us into some recognition of the challenges faced by people with dementia, but can we then end up sort of stigmatizing or othering other people who are within this within care relationships or care contexts? So just that critique, just to underscore what I've mentioned already, I think it's really key to recognize that, avoiding that individualized sense that we almost, like I say, we start with an individual, then we think about their immediate context, and then social and cultural factors are something we add on later. The conditions of the situation are in the situation, where there's no such thing as an action or an activity which isn't influenced by social and cultural factors. So we need some integrated sense of action, context, and social and cultural factors. And those could, of course, be related to matters such as gender as well. And I think I've covered that point there around the malignant social psychology. Okay, it's there to prompt us into the recognition of the challenges that people with dementia might encounter, but does it potentially end up stigmatizing or placing an additional challenge upon carers? As it's stated there, they're almost complicit within the negative experiences that people with dementia might encounter. Of course, we need to be credible about the challenges that people encounter, and of course care relationships could be negative, could even potentially be could be very challenging, difficult, potentially even abusive. But let's not construct some kind of conceptual model whereby we're making any sort of where we're making assumptions. Let's construct models whereby we're able to account for the breadth of experience that people might encounter, without in the first instance generating terminology that could be challenging to informal carers. I'm using the term, all the terminology I'm using is open to scrutiny. Of course, I'm using the term carer to refer to informal carers or family carers. That's potentially problematic in itself. It has the tendency to suggest there's a simple carer cared for dynamic, reduces the relationship to a care relationship as well. As I'll sort of move on to discuss, it's the terminology I've tended to use with an apology in my papers, because if I start in a dyadic or a couple study, if you start talking about partners, it's not quite clear who you're talking about. So I guess I'm using it in this presentation, the term carer, sort of with that caveat and apology. The final concept, just to discuss briefly, is just the recognition that perhaps personhood tendency to be a little individualized is over recent years, I'd say sort of 2007 onwards, in terms of the dementia literature. there's the notion of couplehood that's been increasingly aligned with qualitative studies. So rather than taking the individual as the key locus of analytical interest, we start conceptually with the couple. And I think, again, that's potentially useful. Again, I have critiqued this within my my own research, and I think there's just that tendency that, well, first of all, some obvious points: people aren't always in relationships, and there's also a slight tendency, or I would say more than a slight tendency, within studies on couples to present a positive view of relationships, almost how things ought to be. I think, again, as I'll draw out, sometimes in qualitative research, we obviously, in societally, we have often representations of dementia that can be sort of negative, potentially demeaning. We can see that sometimes in sort of mainstream media. I think there's a counter tendency within academia sometimes to try to sort of provide counterbalance. So but is that really what our goal should be within academic studies? Is it not to convey really credibly what people are experiencing, not just seeking to counter particular representations? So what we end up with so the cat's attacking me now, so he just loves to be on camera. So I'll just move him over there. He'll come back in a second, I can almost guarantee it, but I will deal with that as the situation arises. So what we tend to end up with couplehood studies is, as I've put there, it's more almost normative rather than ontological. It's an academic norm that we're trying to challenge particular representations rather than ontology, the actual status of what there is in the world. So cat's going on the floor. His name's Gatsby, just for the recording, just good to pin that down. And where am I now? Good. Thank you for the heart emoji. We'll pass that on to Gatsby, who is being, let's be honest, a bit of a nuisance, but hopefully he's gone away now. So pin down some of those points I just mentioned in terms of the couplehood, the personhood. What's really key, I think, is avoiding, and it does come through in the literature almost like we've got some zero sum where we're trying to bolster the person with dementia, but perhaps we end up diminishing the status of the carer. So what I've tried to get through in my sort of relational studies is avoiding that sense. And that middle quote there, again, I think aligns with what I endeavour to achieve within my research, is that we don't want trying to create some pendulum swing between dementia is either a tragedy or it's living well. And of course we have absolutely laudable, we have, living well aligned with sort of policy and practice and strategies. But again, it's that need to be credible. And again, I've discussed this in my research about actually not to dismiss the living well agenda at all, but we have to be able to engage critically with it as well. And actually, does it present a standard that can be challenging for people to live up to? But crucially, that the reality experience is more complicated than a simple tragedy, living well binary. And that sounds obvious, but perhaps in terms of our academic constructions, we've sort of constructed this sense of a binary. And of course, as I've kind of banged on about already, that they need to recognise sort of socio-cultural standards and moral discourses as well. And hopefully I'll draw that out over some of my forthcoming slides. So I give it a little bit of a research overview. I've done a couple of studies. I think I'll be drawing on sort of one in particular where I've interviewed couples. So joint interviews, interviewing the person with dementia and their partner together. I've actually done 2 studies like this where I've kind of inverted the gender order. So the first study I did was men with dementia with their female partners. Like I said, joint interviews, so usually quite extensive interviews, 60 minutes, 90 minutes, quite typical. And that enables, well, the joint interview, I quite like it as a method, but it gives me insights into their individual perspectives, if there are such a thing, but also how these are constructed through conversation as well. So there's a hint of an observational component to it as well. All I would say, it's not asserting that one method is better than another in terms of data collection. Of course, there's other ways we can collect data. Would I obtain different insights if I did one-to-one interviews? Yes. almost certainly. But is there something to be gained from that joint interview approach? I believe there is, and ethically there are challenges perhaps doing one-to-one interview when you're, what do I do when I'm interviewing one person? The other person's got to be situated somewhere else in their own home potentially, which again, an ethical challenge to say the least. And it can be experienced as quite a supportive process, two people together, often in their sort of living rooms, kind of playing host. It shifts the power dynamic. There's two of them and one of me as the interviewer. But again, there's no sense, of course, that it's in itself an ethical method. There's no such thing. It's how it's conducted. And of course, there could be challenges associated with it as well. The scope for conflict being an obvious one. Potentially could be pressures as well, that perhaps an interview might not be able to talk candidly within that setting. So of course, we need to engage with it ethically as well, and to consider some of these factors. So as I've mentioned, it was men with dementia and female partners was the sort of the principal study I've got the data from here. That can sort of trigger a bit of a equality and diversity impulse. Why have you only chosen men? But I think in qualitative studies, actually, it's about a coherence, a degree of homogeneity to the sample to generate sort of the coherent insights into what it is we're exploring. And would we dispute that care relationships to some extent are gendered? So for me, a mixed sex sample in that regard, perhaps it's just there's quite a lot to disentangle analytically there. So I think what would be the challenge in terms of when we're thinking perhaps more in terms of equality and diversity is if the whole literature corpus is just on men with dementia or women with dementia, for example. But I think within a specific study, I think actually, like I say, seeking a degree of homogeneity can be value in terms of bolstering the credibility and coherence of the research. And of course, we end up with the sample when it was men with dementia and female carers, about 14 couples took part. That was a large sample. I interviewed people twice with a 6-month gap apart, just to generate additional sort of depth of insights, and adopting a kind of a narrative thematic approach to the analysis, but really a massive data to be making sense of. And it did provide I believe some rich insights, which I'll hopefully be able to just give a nod to now over the forthcoming slides. I will have, and I may even in this short presentation repeat myself a few times. I think whenever we're thinking about gender, I think we absolutely need to consider matters such as gender, but I'm not prioritizing that ahead of other factors. And similarly, whilst I think whether we're a biological determinist or a cultural determinist, would we dispute that gender shapes our experience? I believe it does, but similarly, do we need to fall in some stereotypical or essentialist view of gender? Absolutely, that's also equally important. So it's just that's the sort of caveat to keep in mind as I sort of move on to discuss some of my findings. So as I've mentioned, the joint interview method, probably covered that already, but just giving the insights into the perspectives from the two participants, but also how they combine within interaction. So getting that sense of direct insights into the negotiation of their experience. And I suppose what I was addressing as well, I suppose the overarching aim was to get an insight into how they negotiate their experience of the condition, how they access services, other support they draw upon, for example, from family members. I suppose another thing with a joint interview, as you can imagine, it's not necessarily the case you as much as possible with the facilitation, you try to get balanced input from both interviewees, but usually there is likely to be some degree of imbalance. What I think, as long as it's not too imbalanced, it's still a valuable approach. And I think some of the potential, let's call them shortcomings of joint interviewing, almost become data if we start to think actually some of the points about the way they're negotiating these things, the fact there could be an imbalance, the fact that people might start almost talking on behalf of another person at times. Like I say, if we shift our emphasis to think what we're interested in is interaction and dynamics, then that becomes data, becomes kind of almost a form of observational data. And there's no such thing, is there, as an individual perspective that's divorced from context. What we need to consider as qualitative researchers is the contextual basis within which these perspectives have been expressed. And I've had a nod to ethics already. Anything that, as with any method, it's really crucial. But I think one of the key things I learned was with my sort of joint interviewing studies is that, again, we can't disaggregate people. We've got to think about how the research is impacting on one person and how in turn it impacts upon the other, and sort of recursively how it's shaping the context in each individual. And we'll have things obviously in writing that, you know, make absolute sense. You know, if there's distress exhibited, we withdraw from the situation. I think in a relational setting, well, I think what I'd be interested to explore in future sort of research as well is how we actually apply some of these things, how we take them off the page and we make judgments in real world settings, because it's a lot more challenging within the practice of research to be making these judgments and thinking about what the best interests are of the people we're interviewing than simply just taking a sentence off a page and applying it. So the gender, as I've mentioned, was a factor just by the nature of the sample I'd obtained. And that middle point there, you know, again, when we have dementia, suddenly we start presenting people as though they're gender neutral, that these things aren't shaping their experience. As I've mentioned, it's not the case. Then we start coming up with some simple essentialist view of men, women, and as if all men think the same way and all women think and act the same way, and there's an unbridgeable divide between the two. But similarly, if we're not, it's illegitimate, I would suggest, to consider that a uniform and gender neutral world for any of us, and let's not start to construct it when people end up in later life or with dementia. And that happens in qualitative studies. I've talked about my sampling approach, but actually what I think has been a tendency in qualitative studies, we take a mixed sex sample and then we present it like a gender neutral picture. We don't attend to gender as a factor. As I've mentioned, it's not a case then of prioritizing gender ahead of other things at all. I should just mention, I suppose I've said dementia in my studies. I didn't have exclusion criteria regarding dementia, so it was all types of dementia. Principally, it was people with Alzheimer's who took part in my studies for these two studies. So we'll just move on just to talk a little bit about my data. I think I should be able to, just in the time I have, just to get to the sort of cover the man with dementia, the care, and then just how these are sort of perspectives sort of interwoven within conversation. Just have a little sip of water as well. So for men with dementia, so again, my sample of 14 men taking part in these joint interviews, what came through quite strongly thematically across the interviews, with a sort of focus on being an active person, still sort of to some extent being independent, avoiding and having communication strategies, avoiding a sense of sort of passivity or vulnerability, or being positioned in a way that position the person as dependent. And also, let's call it almost a positive perspective, for want of a better expression. So appeals to sort of carrying on as normal, inverted commas, and continuity, and there being a positive future despite being diagnosed with the dementia. Obviously, that's a distillation in one slide of a lot of interviews and a lot of different perspectives. But thematically, if I was just to distill the orientation of the interviews, that would convey the orientation, the sort of let's call it the sort of preferred identities, to draw on a sort of Kathy Charmas's term for how men with dementia, and I suppose Goffman as well, the sort of the presentation of self. So so like I say, there's a sense of productivity. So for some men, continuing to, say some of the younger members of the sample in employment, but for perhaps some of the older members of the sample, sort of reflecting on the sort of employment and adventure even when they were younger. So I won't read it out because I think there's that issue with reading out quotes, also a hint of ventriloquism to it. But here is a quote, and just I suppose I probably should have given a bit more of a lead in. So I'm talking here about the question was presented about attending a support group, and this is the response from the man with dementia. And this was a man, I think, as I've mentioned, some age. So this was a man in his sort of early 60s who was still working, still driving, still playing cricket, and still leading an active life. And we just see in that quote there the sense that not needing to attend a support group, happy with how things are going, like I said, that sort of positive orientation, but then switching it from the sense that, you know, going to support group where you are the person who would need support, to actually going there to help others. So that sense of that active role, not being positioned as the person in need of help, but being a helper. So there's that. Just going back to that previous slide I mentioned, drawing out just a representation from one quote, and again that sense of improvement there as well. So we have the dementia, but actually through taking positive steps. And for this respondent, I can remember the sort of ways of imposing sort of control, a sense of control on the condition by sort of following the medication regime closely. So almost a sense that you're able to sort of fight back to a degree against the impacts of the dementia as well, from a sort of experiential point of view. So hopefully, I recognise with qualitative data there's that challenge. Obviously, I met the respondent. This is a quote taken out of context, but hopefully it gives some insight. So that's the men with dementia covered within over 2 slides, obviously. From the female carer's perspective, so more negative, let's say, and again, we need to avoid some simple positive negative binary. This is a distillation, obviously, of the research, but almost what I mentioned, what probably came through the strongest in my research were the moral challenges, I think, faced by female carers. So a sense of being sort of judged societally, but not by the notion of being a good carer, potentially aligned with, well, like I say, being a natural female role, potentially aligned with sort of maternal qualities, even, and any sense that you're not putting the other person first, you feel selfish, or feel that you'd be perceived as being selfish. And there was also the need to really to convey candidly the challenges that the carers are experiencing. So some frustration, either challenges, constraints, and whilst, you know, in the joint interview setting, talking about, you know, the difficulties of negotiating the relationship, but then also feeling guilt for feeling these frustrations as well. So I feel frustrated, but I shouldn't be. I'm supposed to be a good carer, in inverted commas, and these are the challenges that I'm experiencing, or the frustrations I'm encountering. And also as being the notion of a good carer, or being the partner, the spouse, that actually I'm supposed to take on the full burden, in inverted commas, and not to let this be sort of dispersed onto other younger family members often, or societally more broadly. And sometimes even some of the carers would talk about being perceived to be sort of like a scrounger. So actually, you know, these are some of the moral challenges that carers would discuss. So this is the next slide is just a couple of quotes from the partner of the previous gentleman I showed the quote from, and I will just give you a couple of minutes just to take a look at those. So give the context again. The first quote is discussing the point of diagnosis, and at that point of diagnosis, the clinician had spoken about life expectancy, and it was very clear. The name has been changed there, but when she's talking, and David spoke not positively about it, but sort of put a positive spin onto how it had been presented, whereas the carer was much more candid about actually this was emotionally far too much to cope with on that day. And the second quote is actually, I think, the support group discussion again. So again, actually some resistance here to attending a support group, but this participant was also their job. They worked as in a clinical role for the NHS, and they're talking here about actually they struggle to go to a support group because actually they feel they go into a clinical way of acting and just would feel difficulties with that. But we can see there the senses that they're thinking about themselves there, and we see actually, if we just even want to just look at the terminologies that use selfish, repeated on several occasions there. So the idea of actually thinking about yourself or the challenges you might individually experience is, well, I'm not being insufficiently selfless. So again, conveys the challenges there of being a carer and being a female carer, I would suggest as well. And I suppose I could have amplified a bit more, and I'm just reflecting on the previous slide around some of those things I talked about with the men, certainly not exclusively male, these things, but that sort of avoiding that dependency, the passivity, being an active agent. My caveats I mentioned earlier on, but are there some pressures perhaps on men feeling, being positioned in some sort of vulnerable, passive sense that could present some additional challenges to men? So my final section just on this is how these then come together, as we have the male perspective, that broadly that sort of positive sense of needing to fight back against the condition, or a sort of stoicism. We have but alternatively the female carer who grappling with these moral challenges, who wants to talk more candidly about the challenges they're experiencing. And how I term this in my paper was a sense of sort of narrative collisions, that we, like I say, we have that the man requiring almost like a positive sense of continuity, things carrying on as much as normal as possible, but that colliding then with the carer who's actually seeking a different communicative strategy to kind of needs to convey the challenges they're experiencing. Otherwise, what they're experiencing isn't really justifiable to themselves. So I'll just draw that up as the quotes, just showing how these things come together. So these are from the two previous participants, and it's just showing again, I could draw up many different quotes that kind of convey these kinds of collisions, but this is just Florence talking about David losing things. This came up a few times across the interview, and just some of the frustrations with that. But then we can see that then puts David in the position whereby he's being positioned as his behavior being positioned problematically. So we have this kind of interplay here where it's the losing things sort of dismissed by David, a bit playfully. Florence then persists, and sort of, again, we can start interrogating a bit of the language, the use of we rather than you. Is that to sort of shield David a bit, or could it potentially sort of belittle him? We need to be tentative with our interpretations, of course, with qualitative data. We then get David again trying to sort of position a bit the challenges he's experienced in the past. So we're going back, I have experienced, we have experienced some challenges, but but now I'm a little bit more, doesn't finish what he's saying, but actually again it's that sense of improvement, he's performing, coping better now. And then the final point from Florence is where you get the sense she's trying to sort of not to back off a little bit, I suppose, in basic terms, not to put too much pressure onto David. So it just shows that challenge of negotiating these perspectives. But that came through really in my research. Again, we're not reducing in any way the experience to positive, negative, and narrative collisions, but was it a theme that came through that I was able to discern? It was, but the key thing is not to, of course, reduce the sense that relational experience was simply captured by narrative collisions. Just a point, I won't dwell on this point, but just another paper I wrote about sort of on strategic interaction, sort of drew a bit on sort of game theory. Is actually when we're trying to sort of we end up with the pressures sometimes in the relational situations to sort of put the other person first. So actually we get almost collisions of selflessness sometimes that can be difficult to unravel. When it's usual game theory, you might come across things like the prisoner's dilemma. It's usually when we're trying to sort of unravel things based on self-interest. But that's what actually happens when there's less written about negotiating things, when there's a kind of pressure socially, culturally to be selfless. Don't think I enjoyed writing the paper on that. It's not one of my most cited papers, and I did actually present on it at a conference, and somebody came up to me afterwards and said, enjoyed your presentation very much. What was it about? So I think maybe there was perhaps something around reconciling something like game theory with some of these points I'm mentioning, which was a bit difficult to convey. Have I got time just to discuss just to convey my sort of second study where I was addressing male carers? So just to get some sense of distinction. So this was a study where I interviewed females with dementia and male carers. And so I've just got just a slide coming up just to show this different aspect, different angle. And for male carers, just a bit of the literature. We had that sense perhaps that women tendency to be seen as natural carers, to be precious, to be a good carer. Some of the literature highlighting actually in terms of masculinity, does it place or leave much scope there as it's put there for nurturing qualities? Perhaps men wish to sort of or seek to reconfigure caring types of role into more masculine type tasks to sort of make sense of caring. But also we need, of course, not to prioritize gendered assumptions that I've mentioned previously ahead of individual factors as well. And again, not to reduce, again, these couple of quotes I've put here, not to say these represent in entirety, of course, how men think about or conduct care. So just the quote there, and these are just for male carers, but it just draw out some of the distinction perhaps from just what I was discussing earlier on about female carers. These are both from the same male interviewee. And we have that sense at the top of that in trying to conceptualize and make sense of his partner's condition. So he's got talking about lotto and the balls. And I'd have to say, I could go on about qualitative research a bit more and some of the challenges of, or some of the things we're not seeking to do. We're not seeking to generalize. We're not seeking sort of representativeness in our samples. We're seeking depth of insights from smaller samples. But still, I would assert with those caveats that I haven't encountered this from female carers, this kind of trying to sort of conceptualize what's going on inside the person's head like this. And also from the second quote, we got that sense there about trying to make things better, but from the carer's perspective. So actually we're going to actually kind of solve the dementia. We're going to kind of cure it essentially through and this was about sort of doing little sort of memory sort of tests with his partner and sort of prompting her to remember things. That's that thing that is, I want us to get better, so I'm going to keep pushing and keep trying to sort of fight back against the dementia. And it would come through again from other male carers, perhaps things such as the diet. So the fighting or pushing back against the impact of the dementia. And again, I would highlight, I didn't really encounter this from this narrative sort of thread when I was talking to female carers. So my final points, just to summarize, it is vital, I would say, to avoid a gender neutral perspective. We don't suddenly have a condition such as dementia and we become gender neutral. Of course, that's the case, but it does perhaps come through, I think, in some of the academic writing. I think I've probably banged on about that middle point enough, but I think it's really equally crucial to get that as well, because we suddenly start talking about men, women and care and dementia. And in a short presentation like this as well, I'm distilling some of the distinctions, but of course complexity is the key thing. And of course, we need to recognize the sort of diversity of people's experience as well. And of course, we need to be thinking about matters such as gender without overlooking other factors that shape experience. And of course, not recognizing as people, we're not simply lists of characteristics. Of course, we're not. It's really important that that sense of relational experience, we consider the complexity of that individual's experience, the relationships and social and cultural factors as well. So thank you. I shall